Yeah.
Okay, great. Hey everyone, welcome. My name is Meena Dayak and I'm the Executive Vice President for Market Intelligence at Open Minds. We are very thrilled to host all of you today for this Executive Roundtable. It's one of the special events we do for our elite members. We love bringing people together to talk about the issues of the day, and you're all probably familiar with Open Minds, and you know that one of the things we have done very well over the years is bring the provider organization executives and the payers together to have these really important conversations. So I am very grateful to all of our panelists today, Kathy, Roberta, Amy, and Sean. Thank you for making the time to join us and to look into that crystal ball or inside your heads to tell us what's coming on the telehealth front. Really appreciate it. And special thanks to my colleague, Deborah Adler, who has pulled this panel together and is moderating the conversation today. So I just want to take a moment to introduce Deb, our Open Minds Senior Associate. She brings more than 20 years of experience in executive healthcare roles, has served in a variety of capacities, including quality management executive, chief operating officer, network executive, and she has specialized in providing consulting services on a broad range of topics, including collaborative care, telehealth network implementation, and strategic planning. If I were to tell you all about Deb's many accomplishments, we would spend at least about 30 minutes just on that. And I know you're eager to get on with the telehealth part of the conversation today. So and this is a roundtable, so we don't have a canned PowerPoint presentation. We are just going to have, the panelists are just going to have a conversation. And then at any point, if you have a question, you will be able to unmute yourself and you can just jump in and join the conversation. Or you can send me a quick chat message, just do the chat on the side of your screen. You can chat everyone or just chat me, Meena, and we'll get you situated and we'll make sure that we get through all your questions. But we'd also welcome hearing from you. We want to know how you're doing, what you're seeing with telehealth, and what you expect to be the future. So I hope this will be a great, lively conversation. With that, Deb, I'm going to hand it off to you.
Thank you, Meena. Look forward to hearing from all of our panelists today. We put this together a few months ago thinking, by July 14th, we should have a pretty good handle on what the future would be as it relates to telehealth services. And I think we've learned that it's ever changing. We're only 10 days away from when the public health emergency declaration is slated to end, but that could be changing as we speak. I do want to highlight, I'm going to do a quick run through of our panelists today. I have Kathleen Mahieu, who's from Aetna. She is the Director of Digital Product Innovation and Strategic Partnerships at Aetna, and I know Kathy well over the years, has spent a lot of time in the behavioral health field doing consulting. So we're going to hear hopefully a little bit of what Aetna plans to do, because if you read the title of our program, we said, what's happening with telehealth? Let's ask the payers, what their plans are. So we're hoping to hear from the payers to the extent they know what their plans are given the changing environment. I also want to introduce Roberta Montemayor. At least on my screen, she's next to Kathy. Roberta is from Optum. She's the Director of Telemental Health Innovation for Network Strategy at Optum, and I know she has been a key part of building their telehealth network and platform, and has spent 25 years in the managed care industry. Not all of that in telehealth, but a good number of years focused in that direction. So we'll hear what Optum's doing. We also have Amy Pearlman, who is representing Anthem and Beacon today, the combined organizations. And there we go. Amy is the Vice President for Clinical Provider Strategy at Anthem Beacon Options, and so she'll be giving us a window into their plans. She oversees the clinical and quality outcomes area on behalf of Beacon Anthem. And then last but not least, we have Sean Schreiber, who is on our panel. He represents Alliance. He's the Executive Vice President of Network and Community Health for Alliance Health. They're a regional Medicaid plan in North Carolina, so we wanted to make sure we included not only a discussion about the plans for commercial telehealth, but also hear from someone in the trenches in a Medicaid program, because we know that adds a little extra challenge to make sure people have access to digital technology. So with that introduction, I'm going to throw out the first question to our panelists, and we certainly hope to hear from our audience as well. But my first question is, what do you think will be changing when the public health emergency ends? What are some of those pre-crisis restrictions that you think will maybe come back into play, reappear? And what do you think will be forever changed? Because I know for me, I do believe that the use of HIPAA secure equipment is eventually going to come back and be a requirement that will no longer be relaxed. But I'm also very hopeful that beyond outpatient behavioral health, we will see other levels of care, some of the restrictions like intensive outpatient that's been lifted during this time, maybe something that continues. But I really want to hear from our panelists. So I don't know if there's a particular panelist that wants to start.
Well, I'll go ahead and jump in, Deb. Thank you. I expect that we will see a lot of regulatory changes that are favorable or at least less restricting to telehealth. I know that a number of congressmen have already introduced bills to state and federal legislative review that keeps some of the, I'll say, exceptions during the public health emergency in place. A lot of the legislation that I've seen has been a little ambiguous. Basically, everybody wants to maintain increased access to the public to telehealth services. So I'm interested to see how these bills kind of shake out. But I think some of the biggest barriers that we at Optum have had to work within are specifically regulatory limitations. So I'll be excited to the extent that some of these CMS and state limitations are lifted.
Great. How about at Aetna, Kathy? What do you think will stay and what will change and revert back to pre-COVID times?
Yeah, it's hard to say for those points that Roberta just made just then, but I think I'm really optimistic here because, as you all know, pre-COVID, trying to get people to use telehealth as a modem for mental health care was almost non-existent. And so we're optimistic now that I think the tide has changed, where people recognize that you can receive mental health services through this forum. And some of the ways in which people have accessed mental health care previously has really been a barrier because it's so difficult to get there. And telehealth makes it easier. So whether it's a digital solution or a televideo, so we're optimistic that the public will be more open to receiving care this way, and I think our data is showing that, but also that the legislators will recognize how important this is to addressing the needs of mental health across all of our members. I think one of the things that stands out to me, so the things you mentioned, IOPs, even PHP, so we even opened up virtual PHP for our membership, but things like medication-assisted treatment, being able to do that via, get that prescription via telehealth as opposed to having to go to an in-person. It just opens up the ability for members to get care faster and easier. And that's really what we're trying to do here. And so from Aetna's perspective, we're all on board with this and want to really take advantage of this opportunity to use this as a way to address some of the access issues that have been plaguing our behavioral health world for so long.
So will you, I'm curious, and for Optum and Aetna, will you continue, both of you are doing partial and IOP is available through telehealth. Will you continue that even if the emergency period ends, or are you still contemplating?
I mean, so
And also,
oh, go ahead.
oh, go ahead, I'm sorry.
No, go ahead, Roberta. You can go first.
Yeah, thank you. Thanks, Kathy. So at Optum, we're still contemplating, our biggest concern, and as it is for any service, we want to be able to increase access to that service by providing it virtually, but we want to make sure that it is clinically effective, that the members will stay engaged in front of their computer for 3 hours a day, 3 days a week, or whatever it is.
Right.
So we are still investigating, but I'm very anxious to hear from some of the panelists and some of our providers if you guys are doing virtual IOP or virtual PHP, how's it working out? What are you seeing, and what would be your recommendations to the payers?
Yeah, I would echo that exact same sentiment in terms of our, it was great to open it up, but we really have to see whether people engaged in it and whether it is driving outcomes. So I agree with you. I mean, I would love to hear from those folks on the call here that might have experience in that and see what their experience has been, because that was a big, a partial hospitalization program, and even an IOP. That's a lot of time to spend at your computer. And so while it sounds great, I don't know that we're, that people will really engage for that long. So
it's funny you say it's a lot of time, because I'm a big believer in tele IOP. I think I've worked with providers who have seen engagement actually improve, that people are staying with the program, the outcomes are better, they're transitioning from IOP into outpatient services, or from detox into IOP at very high rates, and no-show rates are definitely down. So I've definitely seen improvement in some of the engagement and outcome scores. PHP, when I first heard of the concept being delivered through telehealth, I said, oh, 5 hours on Zoom. But then after I said 5 hours on Zoom, I'm like, wait a minute, you're on Zoom 8 hours already.
Exactly.
I'm having the equivalent of an IOP and a PHP every day, but it's not very therapeutic. But I don't know if is there a IOP or PHP provider that's doing tele that wants to highlight anything about what they found in pivoting to virtual? Are they all shy?
Nina, while we're waiting for that, I want to see if Lucas maybe wants to speak Lucas, I'll just let you, if you want to unmute and ask your question, this would be a great time.
Oh, sure. Thank you. So a slightly different topic, but before I bring up my question, you were talking about IOP. My organization serves primarily kids, and we do day treatment, which in our state is a half-day intensive program, so somewhat similar in intensity and makeup to a traditional IOP program. We also have had a lot of difficulty converting that into a virtual based, and found, at least for kids, keeping them engaged for multiple hours, multiple days of the week has been very difficult. On a different topic, the question that I had raised is, we've been doing telehealth even before the emergency. One of the biggest barriers we've run into is a lot of our families have coverage through self-insured large group employers. Those plans for a lot of families specifically exclude telehealth coverage. And we have worked with plans in our state, and the plans have said the best route for us to go is directly to the employers and lobby them to add the telehealth benefits to their coverage. And I'm just wondering if any of you have examples of work that you've done in that part of your portfolio to really help those large employers that might not yet cover telehealth. How do you make that argument? How might you approach them?
That's a great question, because I know it's a real struggle, right? Because you were under the assumption that most people can access telehealth, and then to find that it's not a covered benefit for a self-insured employer. I mean, I would, from having worked as in a payer organization in the past, certainly I would highlight the convenience of access and the ability to access more flexibly appointments. So I think it's a real boost, but I'd ask the other panelists that are in the commercial space, Amy or others.
Sure, and I'm happy to kind of jump in on this one. I think we are really seeing different responses now than we had been seeing pre-COVID. So if we're allowed to have sort of a favorite outcome from COVID, this may be it. I think that what's been really helpful on our piece has really been talking to the employers about having the same quality of care, the same clinical quality outcomes that we are looking at, and really comparing those between telehealth and face-to-face with the added benefit of access. So what I would recommend to any provider, and I'm really interested in hearing some of the feedback from all of you on the call too, because I don't think we have all the answers here, is really understanding what is that workflow and what is that decision about who's appropriate for telehealth and who might you move towards face-to-face, and what are the outcomes look like between the two pieces. So I'm sure that all of you are tracking clinical and quality outcomes. And what we're really looking at this point in the pandemic is understanding those outcomes and as they vary between telehealth and face-to-face. I personally am feeling pretty hopeful that we'll be able to make our case, but I really think we won't be able to make our case unless everyone on this call is doing that together.
Yeah, I'll also add too to that, because I think one of the things that we heard from a lot of our customers who were not on board with telehealth previously was a concern, not only that you raised, Amy, about the quality, but also the potential to raise costs, right? Because employers are worried about their bottom line. So if they introduce and promote telehealth, they expected that that would cause an increase in utilization and therefore cost. And we certainly didn't find that previously. And now it really just provides a different access point for people. So I would say even trying to make the case around the fact that this is not going to exponentially increase utilization. It's really just opening up access and giving people another avenue to get the treatment that they need.
Yeah, in fact, Roberta, I think in Optum, pre-COVID, we didn't have enough data, Amy, right, to be able to look at outcomes, right? The numbers were so small. Now you actually can. And I know that fear that utilization was going to go through the roof and, length of stay would increase. I don't think that's been the experience, is that actually outpatient behavioral health services delivered through telehealth seem to be more efficient. Could be lower episode length because maybe the individuals are lower acuity. That could be the reason. Or it could just be that it's more efficient. But Roberta, I know you have some experience with that.
We do, and that's exactly what we're seeing, and I think, so to echo Amy and echo Kathy, we know that faster access to care results in better outcomes. And I'm sure everyone on the call agrees with that. And you can achieve faster access through telehealth. That education is key for those customers. We're not seeing an explosion in telehealth utilization on top of in-person utilization. We are seeing a reduction in higher levels of care when our members get the care they need sooner at a lower acuity or a lower level of care. And so I think education to those employers is key on those points.
I'm going to switch the topics a minute because I know Sean is in the Medicaid space, and when we've certainly seen this explosion of telehealth use, but many of us probably on this call, have access to Zoom and internet. So I'm wondering, how do you manage that in a Medicaid program where you have individuals who maybe could have once used the library to access the internet. Now that's not even an option. So I'm curious, Sean, what you're doing in the Medicaid realm to tackle individuals who don't have digital tools.
Thanks, Deb. I think it's interesting. We've been pleasantly surprised at how quickly providers were able to make the pivot to telehealth, but also how the volume of members that seem to respond. We've been looking at our claims data just to track. And I don't know if it speaks to the high volume that people have been able to adjust and receive telehealth visits or the low pre-COVID volume, but we have like a 9,000% increase in telehealth visits this April compared to last. So to give you an idea, it was just not well used. So I think the notion is that a lot of people do have access, but we've noticed some particular challenges. I think the gentleman who talked about day treatment highlighted one. In North Carolina, we were kind of lucky, as a Medicaid managed care organization, we're really kind of acting on the authority the state gives us. So we don't really have the full ability to set our own policy. But one thing they were able to do is when they implemented the ability to do telehealth in like psychosocial rehabilitation programs, day treatment, and the substance abuse outpatient intensive programs, they actually ramped down some of the hour requirements. So instead of saying an SIOP had to be provided for 3 hours, 3 days a week to get billing, we're able to get a compromise. It just had to be available so many hours of the week, and that seemed to help. With day treatment, one of the flexibilities to really make it work and actually to help the network be sustainable, so we basically had to almost double the provider rate, knowing that utilization would be roughly cut in half, that it would probably be not very tolerable for members to have maybe 5 to 6 hours a day of telehealth. Again, a unique position because some of that's funded by the state. So we're not having to go back to an employer and say, we need to raise rates and offer maybe a little less so we don't get some of that response. The other thing we've had to really do is for some of the higher risk populations is really find ways to more quickly get telehealth equipment to their hands. So a combination of actually providing kind of seed money to providers to go out and purchase smartphones in minutes, and to some of the more hard to reach groups who say go to psychosocial rehabilitation but reside in group homes, actually buying equipment to put in group homes so the group homes, the members in group homes could still kind of have access to their services. So for us, it was flexibility, but we had to use some of the federal funding that came through us, through the state, to really help build some infrastructure as well. So again, I think to your point, just having the codes helped some, but kind of looking at how to address some of the typical barriers you see within a Medicaid program became really important to us as well.
Interesting. You mentioned a very important topic, which is the reimbursement rate. And I know for behavioral health services, telehealth has typically been paid at the same rate as the face-to-face services. Not so true on the medical side of the fence. I know, many of the payers have, pay a discount on the medical side because the idea that there's less overhead. I believe the reason the rates have been preserved, if you will, on behavioral health is just because of the workforce shortage, right? The national shortage of psychiatrists and even shortages in some markets of other behavioral health specialists. So I'm curious from the payers, I know there's a lot of fear in the provider community that given now telehealth has become a much more common modality, do you think there are changes coming around the bend to modify that stance that telehealth for behavioral would be at the same rate as face-to-face?
I think, is it 23 states that have provider reimbursement parity now? Regulated, and I think we're going to see that number increase. So, my thought is that on the behavioral side, I don't believe that we're going to see reimbursement change. Now, I have no idea. We have no reliable data to talk to anything that we're going to talk about today, right? Because it's just been such a weird past couple of months. But that's exactly right. I mean, we continue to improve access via telehealth to needed behavioral services. Might we not be doing ourselves a disservice by altering the reimbursement and, providing another barrier to access? So I hope that it does not change and that virtual services continue to be reimbursed in parity with in-person.
We have some audience members, Mina, that I think want to have a chance to speak.
Absolutely. And I would invite you all to turn on your video if you feel comfortable. If not, you can just do audio. We are talking telehealth. So do whatever you're comfortable with and chime right in. Sandy Potter, you had an interesting comment you were sharing through the chat about your fears with face-to-face for IOP, if you have to resume, and you're in Texas, I believe. So if you want to come on and talk to us about it, that'd be great.
Sure. I mean, we have a very high infection rate here in the Dallas-Fort Worth area right now, with a lot of our medical surgical beds actually getting full at Texas Health Resources. So, you know, we've seen in the last 2 weeks since the, I like to call it, re-explosion of the virus, that our numbers are starting to drop off again, which always concerns me on the outpatient side, because we don't want people to decompensate and end up in the hospital. So if we lose the capability to do the virtual IOP, I think those folks are not going to be coming in face to face.
Yeah, it'll be a barrier to access and a quality issue if they come in and the infections increase.
Right.
And hi, Sandy. Good to
Hi,
hear
Deb.
you.
Yeah, and you know, we decided to not do partial virtually, and we've had very good compliance with individuals, you know, sitting in the group rooms. They're very large. Sitting more than 6 feet apart and wearing masks. And we've been taking temperatures all the way back to the beginning of this, mid-March. So the virtual IOP, virtual partial, we never ventured into, and we've had good participation for the partial. As you know, that's keeping people out of the hospital because they wouldn't be in the program unless they were on the edge of needing to be in the hospital without their support system standing with them. But again, I see the IOP as essential to continue virtually. I will agree with the man that spoke earlier about adolescents. In our adolescent IOP program, the engagement is so much harder. So we're working on some new strategies and training and techniques around engaging kids virtually. I personally think it's a great effort to do because these kids are likely to be attending school in an online setting. So it's, I think it's critical for their futures going into the fall that we figure out good ways to engage them and not have them dropping out.
Yeah, it's so interesting because you automatically think that, oh, the kids are the ones that are going to adapt to this so easily. But there's also the attention, right? And being able to sit in one or stand, whatever, in one place so that you can engage in that kind of a experience. So yeah, that's interesting. I appreciate that comment about the kids.
Yeah, it's actually the opposite of what I would have expected to.
Yeah.
And the adults love it. So it's definitely an engagement tool. And our partial length of stay is shorter so that we can get people into a safer context in their IOP program. So it's working great for the adults, but the kids, it's a much different prospect.
I think if it were an outpatient, follow-up visit, kids love it, right? I remember early on in the telehealth days in Sunflower, Mississippi, a child that said, I don't want to see my psychiatrist in person again. I like talking to him over the video, but that's a much shorter visit, right? So that engagement for an IOP would be tough. Samantha has a good question about the co-pays that have been waived. That I suspect is going to possibly end, but maybe not. I don't know if the commercial insurers are thinking about whether there's some benefit to waiving or lowering copays to encourage people to access services even when the emergency period ends. Any thoughts on copays?
Yeah, I can chime in here because this is really important to us, making sure that we, as Karen Lynch, the president of our commercial business and our Aetna health plan, says that we are gearing up for the second wave. Well, now who knows what number wave it is, but the second wave of COVID will likely include, some significant resources needed for mental health services. And so we don't want to forget that could be a lag from the kind of crisis that people are in from a health standpoint, and then where it leads from a mental health standpoint and allowing people to get that care. So, I think most of us on this call from the health plans have extended those waivers until the end of September. But we are going to readdress that to see if we should really extend it even further, knowing that, now there's been flare-ups and other states that have lagged behind the initial states in the Northeast and so forth. So I think that's still an open issue, but we're certainly open to that.
Kathy, thanks.
And I
Amanda can come in for a second. Oh, I'm sorry, Amy, go ahead after you.
Oh, sure. No, I was going to echo the same thing, that it feels like a bigger question than the copay piece, and really a question around, when we say beyond the pandemic, what does that really mean? Because I think there is this public health emergency that is out there, but then there are these waves that are coming and going, and it's just really not a finite piece that we are looking at. So I expect that this will not be a turn it all off on one day, even if that day is at the end of September, and that we'll need to think about phasing things in and out over time.
Mm-hmm. Yeah, Amy, thanks. I just wanted to bring Amanda, if you're still on or you want to come back on camera or just speak, whatever you're comfortable with. You had an interesting comment in the chat about the use of substances and people not reporting it. I thought that was a different dimension. Would you speak about it?
Yeah, so I am at a mental health and substance use treatment facility in Eastern Ohio. And when telehealth started up, all of our clients seemed to adapt really well. We were doing IOP, other substance use groups, and individual MAT treatment. And the agency kind of went from be selective about who you drug screen, keep distance, wear your PPE, to no drug screens for a while. We absolutely don't want you around anyone that close in the bathroom doing drug screens. And we're finding slowly that a lot of these clients who were reporting no use were indeed actually using, but because we had suspended drug screening, we weren't able to catch that. So that has been a struggle to kind of clean up a lot of what has happened during COVID in terms of substance use. So.
Anybody have a solution to that challenge? Because it is. I mean, I know some provider organizations have collaborated with the lab companies, I guess, to do some at-home tests, but at the same time, it is a conundrum that Amanda brings up, is how do you stay on top of the drug screenings with this new socially distant world?
You might be able to, this is Brian Salmon, you might be able to do some random drug screens. So you pull in one person every couple of weeks and don't tell them until the day of, so that it doesn't become something they plan for. And you could grab 10% or 15% of your people each week and do a drug screen, which sounds like your staff were already doing. And that way no one knows when the screen is going to happen and they can't plan ahead for it. So you can catch people in that process.
I think it will be interesting to see what the end result is. So to some degree, when I think about substance use treatment, I think one of the goals we all want is people just to be engaged and stay engaged. And so the fact that people are still showing up, they're doing the telehealth during a pandemic, maybe that's not ideal, but maybe it's still pretty good. And I would wonder, if you look back at this period, were there any more adverse kind of events that people experienced as a result of not being able to test? and just be able to dialogue instead. Again, I always think for substance use treatment, just people coming every day is kind of half the battle. So again, I'd be curious to see what the final outcome is from not being able to drug test for some period of time, if it really is a huge change in treatment outcome.
And just to take it in a slightly different direction, David, you've asked the $1 million question. David Ventrell, you have a really good question about use of platforms. So I see you put that in the chat, but if you want to come on, we'd love to hear from you.
Sure. So one of the things that we've recognized pretty consistently is that everybody seems to have their own requirements. One company wants this platform, one company wants another platform. It's been a real big barrier because we obviously aren't going to invest in our staff having 10 different platforms and then trying to select based upon the payer which platform they need to utilize. So is there some sort of a plan that's looking toward the uniformity of platforms so that we can really invest in one platform and move forward instead of having that as a barrier that we need to select?
I have some comments on that. I mean, most of the payers that I've known have not prescribed a specific platform. They were prescribed that it be HIPAA secure, at least pre-COVID, and maybe going forward. Most of the payers that I'm familiar with require that you attest that you are using a HIPAA secure platform, but they don't prescribe the platform. They might make, I think what you may be highlighting though is sometimes the payers use specific vendors to help fill in access gaps. So they might, prescribe a particular platform, but that's really more of a vendor relationship. But any of the other payers want to pile on to that answer? Are you prescribing a specific platform or really encouraging most telehealth occur through a specific vendor?
No, from Aetna, yeah, I think exactly what you said, Deb. Like it really boils down to the security of the platform as opposed to the actual platform. So we just want our providers to be able to deliver services that way and as effectively as possible that works best for them. So no requirements from Aetna that I'm aware of.
I agree, from Anthem and Beacon.
And Optum as well. We're platform agnostic as long as it's a HIPAA secure platform.
And same in Little North Carolina.
I think that's somewhat a shift because when I look back years back or pre-COVID, in some cases sometimes you might call a payer's call center and be told, oh, we don't do telehealth unless you're part of XYZ vendor. But I think that really shifted to really opening up to the network, delivering through that modality, through whatever HIPAA secure means that you have. For the most part, that's at least been my more recent experience.
And Deb, if it's helpful, I can also speak a little bit to this idea of telehealth platform versus telehealth vendor. And I think that something kind of pre-COVID that Anthem and Beacon have been doing is, I think folks on the call may know that both Anthem and Beacon before the merger had their own telehealth vendors that we would use to expand our network. And that's not something that means that other providers could not be delivering telehealth. That's really seen as a network augmenter for providers who were less interested in offering telehealth when there was face-to-face options. I think the other piece that we've really wanted to do is to not decrease access by taking slots away from a face-to-face or bricks and mortar component and transitioning those to telehealth. We really wanted to use a telehealth vendor to increase access. So I think that framework sometimes gets it confused with a platform, but I think it's helpful to kind of talk about what that looked like historically and what we would see in terms of kind of what that may look like in the future. But right now, vendors are just being seen as a network extender, not necessarily there to take the place of any of our valued providers that are interested in delivering telehealth and face-to-face.
Yeah, and I think, and I'm not no specific payer here, but excuse me, sometimes that messaging takes a while to get to permeate throughout the organization. So you might hit upon a call center agent that still has the old memo, if you will. Excuse me. And I know, Roberta, you contract directly with providers who use HIPAA secure means, but you do also offer a platform, not to make it even more confusing, but you do offer a platform for those that don't have don't have access to a HIPAA secure program.
Yeah, we do. So Optum also offers a telehealth platform for our contracted providers to use. The goal being, we wanted to encourage providers to include the virtual modality into their practice. And we wanted to remove as many barriers as we could. So we offer a platform, but providers are not required to use the Optum platform. And in fact, in 2021, so the platform is for use for Optum members only, but in 2021, we'll be expanding that for use with all clients and patients, not just Optum members. So that's pretty exciting.
Oh, wow. Hey, Jessica Dunbar, she makes a good point here about hybrid services, you know, a combination of both, sometimes tele, sometimes face-to-face. Jessica, do you want to comment on that?
Sure. I just wanted to share that we've really had this experience with our mental health center that we really need to offer the full spectrum. For example, with kids, we find that, you know, it can be really helpful to establish a therapeutic relationship in person and then move to virtual you know, appointments, and then maybe have a check-in in a couple months in person again. I just think we need to really think outside the box and be really fluid to meet various needs of people.
I think that we've seen that in our OTP programs that we contract with, that the ability to be able to, you know, go, you know, maybe once to 3 times a month to get take-home doses, but be connected still for some of the support development through telehealth, I think is a nice example of that kind of hybrid. I think that works when you have, you know, you're lowering the risk of some of the face-to-face. There's still some of that contact with, I think, brings people more comfort, and then the ability, you know, have better access to the outpatient services that are more convenient for the members. So I see that as a nice blend there as well.
Will, I know you've been online here. Do you want to, did you have a question or comment? Oh, we have to turn the mute button
Well,
on.
I think there's an audio issue again. We don't hear you. I know you were trying to get that sorted out earlier.
Yeah, we can't hear you, Will. Sorry. It's like a Saturday. I don't know if anybody's seen the Saturday Night Live skit on Zoom. It's pretty hysterical. But,
yeah,
no,
feel free to chat your comment in, and I'll be your voice if you like.
There you go. Well, while Will's putting that in the chat box, maybe talk a little, well, 2 things. I wanted to mention about hybrid. I'm a real believer in having that flexibility that Jessica mentioned, although I have noticed that provider organizations attempting to do that, it can be a bit of a scheduling challenge, right? If you don't know if someone's going to come in or work or access services from home, not work from home, but get treatment from home, trying to plan your staffing model can be really challenging, because especially if it's a group session, maybe not so challenging for individual, because you can have the advantage of having a smaller physical footprint, right? If some services are offered off-site. So I don't know if any of the provider organizations have come up with a nice recipe to figure out, you know, how do you do your staffing model in a hybrid world, because I think that can add some challenges, particularly if you're doing group sessions.
And you all hear me now?
Yes.
I'll figure it out. I can do this. Hey, so anyway, a quick introduction. I'm Will Lopez. I'm National Medical Director of Cigna, and I'm National Medical Director for Virtual Care. So a lot of what I do is deal with telehealth and virtual and all that. And I want to make some comments about something that you already talked about, reimbursement, copays, and all that. You know, in general, related to copays, I think for the commercial book of business, the challenge is that it is sometimes in the benefit language, and that is established by the employer, the clients. And it goes back to the point that someone brought up that, you know, we need to educate employers of the need for telehealth and how it's a modality that really is bringing access, more convenient for customers. And that also helps with absenteeism and presenteeism, because, you know, you won't have an employee going for 2 hours for a doctor appointment where they can be there just for 10 minutes or 15 minutes for an appointment. So I think at the higher level, we need to change the talk track with employers so they understand the importance of reimbursing and the importance of the value of eliminating copays. So once they buy into it, then you can go back and change the benefit language, which they pretty much determine. And you know, with the reimbursement, the other challenge is that in general, employers have this impression that telehealth is going to bring lower cost, and you know, it may not be necessarily the case. So that's another area where we need to kind of reposition telehealth. And you know, the savings are not in paying less for the sessions, but on maybe referring patients to high-performing provider groups, or you know, or all the other things that go along with improving access to care. So that was it.
Well, glad to have another national payer on the panel to join us, Will. Thank you. Great comments. You know, you mentioned metrics, and there's a question here from John Driscoll about, you know, are the payers looking at any specific performance metrics or quality metrics for virtual care? Are there different metrics that come into play when you're looking at provider performance or consumer outcomes when it comes to telehealth?
I can take this one. It's a little bit of my passion project. So I saw that question in the chat and I was getting a little excited. So I think the first part that I would start with is that we really are trying to make the case about having the same quality and clinical outcomes and having those metrics, right? So I would just start with that piece of it. And then I think some of the additional pieces that Anthem Beacon have been looking at have been kind of programmatic outcomes. So instead of looking at what this look like for each individual person, learning from our providers, what does the program look like? How are you being thoughtful in terms of your like standard operating procedures? How do you handle a crisis? These are the types of questions that we think of as a programmatic level that would look different over telehealth than when someone is in the room with you. But in terms of the clinical and quality outcomes, I think we really are looking at the same metrics, but if they look any different based on kind of the service delivery model. And I hope that that's not giving you a list of metrics, but I hope that way of thinking about it resonates with the group. I think I would probably say this about my colleagues on the panel here as well. None of us came into this being an expert in COVID. And I really think we are here to learn together around what is it that we need to put in place. I want to take the outcomes that we've learned, make a difference in behavioral health care from over time. And I don't want to throw them out because of the service delivery model, but I also want to think about what may we add that is more around infrastructure than individual outcomes.
I think that was really well said, Amy. I agree with what you said.
Yeah, because I like the programmatic component, because I think a lot of the measures are the same, right? Readmission rate, ambulatory follow-up, engagement rates, NPS. But what are you doing differently to assure privacy and security and, like you said, manage a crisis? Because, you know, in the face-to-face world, you had access to different tools. If you're delivering services like we're discussing today and someone has an emergency, you know, do you know the GPS location of where Kathleen Mahieu is today if she, you know, had an emergent need on this call? I mean, there's totally, and you know, how do you handle, I know some of the IOPs and partials that I've seen, you would educate the consumer to only put their first name in, right? So you would, like today, we wouldn't see all these last names because of the privacy and security. So there are programmatic changes, and I wonder if any of the payers are looking at changing their credentialing criteria to say, you know, we want to set a different bar for virtual services because there are some other elements you have to pay attention to.
Well, I'll jump in first. I guess, you know, CBH, we have been reimbursing for behavioral health services for telehealth for about over 3 years now. And what we did in our medical necessity, we just put a statement that the expectation is that the provider will use HIPAA compliant technology and obey the state regulations. We didn't want to be too prescriptive. The way we thought about it is just like how they manage their medical records. You know, they're responsible for the PHI, no matter if it's electronic, virtual, or paper. So we're not contemplating making any changes in credentialing because we see that more as a barrier for providers. So we just we think that they're going to do the right thing and provide the security for the customer. They're responsible for that.
So Deb, what we've seen in North Carolina, the Medicaid program, to the doctor's point about eliminating barriers, there used to be a restricted group who could even bill for telehealth services. So it used to be limited in the state to physicians, I think LCSWs, and I think nurse practitioners, maybe PAs. So now they've extended to LMFTs and licensed professional counselors, psychological associates. So I think they've expanded the field. So I think obviously we need to be looking at quality and making sure there's appropriate supervision and oversight. But I think the bigger focus has still been on access. And we probably are not looking to change how we credential providers for telehealth.
Okay, great comments on credentialing. Well, I know we've got maybe 5-7 minutes left, and I'm going to steal Matt's question. Matt Sparling, I think it is, has a great question in the chat. That's a good wrap up as well. His question is, what service delivery surprises came up for our payer partners as telehealth services have expanded so rapidly, both positive surprises or challenging, not so positive surprises? So is anything that has surprised you during this rapid expansion of telehealth during the COVID pandemic?
So I'll start.
I have a couple anecdotes. You know, I oversee both medical and behavioral health, so I've seen a couple of claims for childbirth and for immunizations. So those are, you know, otherwise, you know, I think that on the positive side, I think, like, for example, is kids going to college and being able to connect with someone remotely has been a great positive thing for us to be able to support. So.
Immunization via telehealth. Okay, all right, Sean.
All
Sean?
kind of claims, you know, those, I don't know, you know, we deny.
That's a claim. Okay.
We haven't had surprises at that level. I think one of the things we're concerned about is that while we're seeing engagement for individuals who are involved in care kind of almost grow over the time, we are seeing that newer members we're not seeing the growth of new members coming into care. So we're a little concerned that there may be some barrier that, and curious how providers are handling kind of, you know, basically bringing new members into care via telehealth, because I think we've definitely seen fewer new assessments and, you know, some decrease in new member access as opposed to engagement. I think that's been, I don't know if it's a surprise, but an area of concern for us anyway.
That's a good one, because that use more people that were already in care are looking to access through this modality, but I noticed that in the addiction space, not much new patient growth until more recently, actually. Anybody else?
Yeah, I'll just share that, you know, I was actually just looking at some of the data today from on our telehealth providers in terms of who's using those services, because I wanted to understand, are we getting new people into, and this is just individual therapy, these are not kind of in IOP programs and so forth, but what was interesting is that there's a growth in the use of telehealth as first-time users for teens and adolescents. So that kind of that young adult, kind of 18 to 29-ish age, we really saw a growth in the number of new patients come into using that telehealth service, brand new patients. So I felt like, I mean, I don't know what's driving that, whether it's the parent kind of pushing their child, getting help, knowing that they might need some now that they're home with them, or you know, that they're acting on their own. But I found that an interesting trend, something that I thought was really positive.
Yeah, I think, you know, to the degree that our providers embraced telehealth, new providers, not just during COVID, but providers that wanted to attest to be in our network going forward, I was very pleasantly surprised. And the degree of flexibility that our providers have shown and have afforded us as we continue to try to keep up with the changing timelines and the changing regulations, you know, I think maybe on the not so positive side, trying to keep up with the changing timelines and the changing regulations, which, you know, for my colleagues that weren't used to telehealth, I said, well, welcome to telehealth. This is how it works.
I think it's really, I would echo what Roberta is saying in terms of that level of flexibility and resiliency and patience. So I think even as evidenced by today's call, I think many of us kind of set up and scheduled today's call thinking we would be able to give you all answers. And I think we're in a place where we really aren't able to give answers, but the sense of being able to be in it together for the best interest of people who need behavioral health services and trying to get those services, it's really been a refreshing experience to partner around that, even though I think we all share this frustration of not knowing when is this going to end and what does it mean, and having all of the concrete answers. I think the resiliency, the flexibility, and the partnership in learning about this together, I think it has not just challenged our providers, but it's really challenged us as payers to think about how do we deliver services and how do we incorporate the individual experience, the family experience, and the provider experience into what our future strategy will look like.
Great. Well, I'm going to turn this back over to Mina. I don't know if there's any closeout question we want to squish in 2 minutes, or if we need to wrap.
I think one question, what are you thinking about reimbursement for text message-based therapy services as well as audio services moving forward? Thank you, Chris, for asking.
From Optum's perspective, Chris, we have a provider in our network that offers text-based therapy today, and we very well may move toward telephonic-only services in the future, so stay tuned. I expect in 2021 we'll expand the types of virtual services that our providers can offer.
Great. Anyone else?
I would say from the Anthem Beacon side, this is a TBD, and we'll stay tuned to figure out what the piece is. I think some of those components, we really would go back to that piece of looking at what the outcomes are, what the access issues are, and the feedback we get from providers and members around receiving services through different modalities.
And maybe HIPAA secure, that's the other extra added layer of challenge. There's certainly vendors that have secure message platforms, but you know, your typical texting message isn't very secure. But yeah, there's a lot of other digital tools beyond telehealth, audio, video, real time, right? You know, monitors and all kinds of different tools.
I will say, so just from the, you know, I'll agree with Amy on the their approach with Beacon and Anthem, but for Aetna, same for us. But what I will say though is that our horizons have been broadened. So there is more of an appetite to consider those for behavioral health going forward than there ever was before. So that's a positive note going forward.
I think that's it in terms of questions. Hopefully we got to everyone. If we have just one more second, Kate Sheldon, I think you had an interesting comment earlier. You were answering the question about outcomes. You provide autism services and you will, yeah, great. Kate.
Hi, yeah, thank you. So we do provide some individual mental health therapy as well, and we've seen the outcomes that many others have mentioned, and we've seen great responses from our patients who are really enjoying the telehealth component. But specific to our autism services, the majority of our services are ABA, and we've been tracking the data, and at this point it's preliminary data. We've just been doing this for a few months, and we're hoping to see this confirmed as we continue to track the data. But what we've seen so far is that as we've been able to improve the frequency with the supervision of services being provided, then the clinicians can adjust their treatment planning in real time instead of waiting for the next month when otherwise they would go in person. So as they can update the treatments and the goals for the patients, then the patients can continue to make progress towards those next goals. And so we're seeing them hit through those targets quickly, and
Wow.
they're on track to graduate from treatment faster than we had anticipated that they would from in-person treatment. So it's been exciting so
Boy,
far.
that's really exciting. Interesting.
Yeah, definitely. Again, more data to come, but it's been great so far, and we're really hoping to continue to at least provide a hybrid model for telehealth and in person.
Awesome. And where are you from?
California.
California.
Mhm.
Cool. Awesome.
Yeah.
Great work.
360 Behavioral Health.
Got it.
All right. Thank you.
Great. Thank you so much, Kate. And Deb, did we lose you? Was that a sign that we should wrap up? Okay. While we wait for Deb to come back, I'm just going to go around and see if you have any wrap-up comments or parting words of wisdom to leave us with. Kathy, we'll start with you.
My only words of wisdom, if there are any, are, just to be flexible. And I think that's what we learned here, is that people need choices depending on their situation. And I think this definitely demonstrated that. And I think what has been really remarkable to me, as I think others on the call have said, is that the providers that we work with have been incredibly flexible in jumping to a new platform on a dime. So kudos to behavioral health for doing that so well.
Thank you, Kathy. Roberta?
Yeah, so what Kathy said, we thank you for sticking with us, and your feedback is really important to me. The goal is to increase access to behavioral care to help people lead healthier lives. And so we are, in line with state and federal regs, but also in line with our providers' experience and what our members need. So we appreciate your feedback and response, and thank you for your support.
Great. Do you want to go next, Amy?
I figured it would be me, and I think that that my colleagues here have said all the good stuff already. But I really just wanted to say thank you. I think that being part of the conversation together and figuring out what our solutions are really helps us to inform the future. So I appreciate the flexibility. I think we responded very rapidly on both. From both perspectives, and what I would really like to do is to see what can we do to make sure that we build the infrastructure to respond in the most, in the best way over a long-term solution, because we really focused on rapid access over time. So I look forward to continuing that partnership and figuring out the best way to respond in something that's sustainable.
Great, well said. Thanks, Amy. Sean, you can't let a woman have the last word, so wrap it up.
Thank you. And echoing all the panelists, really appreciate the flexibility of providers in our network. And we kind of see this as a great opportunity. Finally, like technology-enabled care seems to really becoming now what should be the new norm for how an option for delivering behavioral health. And we look at that to really other areas where there's underserved populations. So we think about individuals served on home and community support waivers who require a lot of face-to-face attendant care. And there's so much technology that can really be leveraged to extend the workforce, minimize individual risk, and hope that just telehealth is just the beginning, and really explore in behavioral health a lot of other technologies that can better enable care. And again, thank you for the opportunity to be on this panel today.
Absolutely. Well, Sean, Amy, Roberta, Kathy, Will, and everybody else who attended today, thank you so much for taking the time to be with us. And we really appreciate this sharing, and we hope that you will come back. We'll get together with all of you and figure out a way to have you come back and continue the conversation with more of our members and our provider organizations. So thank you. Hope everybody has a great rest of your evening, and that you stay safe and healthy as you take on these new challenges that we seem to come up against every day. If you have any follow-up questions, feel free to email us, openminds@openminds.com. That's the easiest one email to remember. And we'll make sure we follow up and get you the answers. Thanks again. Bye.
Thank you.
Are we supposed to leave too?
You can hang out. Happy
That was my question.
Take care. Very nice to meet everyone.
Yeah, you as well, Sean.
I agree.
Take care. Bye-bye.
We'll be in touch. Thanks, Sean.
Bye.
Bye.
Bye-bye, everyone.
Bye, Kathy. I'll figure out what happened to Deb.